Meconium aspiration syndrome. Definition: Meconium aspiration syndrome is a respiratory distress in an infant born through meconium-stained amniotic fluid whose symptoms cannot be otherwise explained. Respiratory distress in an infant born through meconium-stained amniotic fluid. Composition of meconium: epithelial cells, fetal hair, mucus, bile. Epithelial cells, fetal hair, mucus, bile. Causes of MSAF: normally the passage of meconium from the fetus into amnion is prevented by lack of peristalsis, tonic contraction of the anal sphincter, terminal cap of viscous meconium. Fetal maturation post-term, vagal stimulation by cord or head compression in absence of fetal distress. In utero stress, hypoxia acidosis producing relaxation of anal sphincter. Risk factors for MAS: maternal hypertension, maternal diabetes mellitus, maternal heavy cigarette smoking, maternal chronic respiratory or cardiovascular disease, post-term pregnancy, preeclampsia or eclampsia, oligohydramnios, IUGR, abnormal fetal HR pattern, heart rate pattern. Risk factors for MAS. Pathophysiology: mechanical obstruction of airways. Thick and viscous meconium lead to complete or partial airway obstruction. With onset of respiration, meconium migrates from central to peripheral airways. Complete obstruction, atelectasis. Partial obstruction, ball valve air trapping. Risk of pneumothorax 15 to 33%. Pathophysiology: chemical pneumonitis. With distal progressing of meconium, chemical pneumonitis develop resulting bronchiolar edema and narrowing of the small airway. Chemical pneumonitis with distal progressing of meconium, chemical pneumonitis develop resulting bronchiolar edema and narrowing of the small airway. Surfactant inactivation: bilirubin, fatty acid, triglycerides, cholesterol content of meconium inhibit surfactant function and inactivation. Pulmonary hypertension: meconium in lungs stimulate release of pro-inflammatory cytokines and vasoactive substance which cause pulmonary vasoconstriction. Also, hypoxia, acidosis, and hyperinflation contribute to pulmonary hypertension.
Pulmonary hypertension. Meconium in lungs stimulate release of pro-inflammatory cytokines and vasoactive substance which cause pulmonary vasoconstriction. Also, hypoxia, acidosis, and hyperinflation contribute to pulmonary hypertension. Pathophysiology of meconium aspiration syndrome. Physiological meconium passage. Meconium stained amniotic fluid. Fetal distress also will cause meconium stained amniotic fluid. Then postpartum aspiration, intrauterine grasping, both will cause meconium aspiration. Meconium aspiration will cause airway obstruction, cytokine induced pneumonitis, surfactant inactivation. So meconium aspiration causes three things: airway obstruction, cytokine induced pneumonitis, surfactant inactivation. Airway obstruction will cause pulmonary air trapping, atelectasis, ventilation perfusion mismatch. So, which will cause hypoxia and acidosis. and cytokine-induced pneumonitis will also cause hypoxia acidosis. Surfactant inactivation will cause decreased lung compliance, and decreased lung compliance also will end in hypoxia acidosis. Then these all will end in persistent pulmonary hypertension. Clinical features: infants with MS must have a history of MSAF. They often are term or post-term. IUGR, many are depressed at birth. Physical examination, clinical features: evidence of post-maturity, peeling skin, long fingernails, and decreased vernix. The vernix, umbilical cord, and nails may be meconium stained, depending upon how long the infant has been exposed to utero. In general, nails will become stained after 6 hours and vernix after 12 to 14 hours of exposure. Umbilical cord staining: thick to 15-minute, thin 1 hour. Umbilical cord stained with meconium. Clinical features, physical examinations: affected patients typically have a respiratory distress with marked tachypnea and cyanosis. Use of axillary muscles of respiration are evidenced by intercostal and subcostal retractions and abdominal paradoxical breathing, often with grunting and nasal flaring. The chest typically appears barrel shaped with an increased anterior posterior diameter caused by overinflation. Auscultation reveals rales and bronchi immediately after birth. Some patients are asymptomatic at birth and develops worsening signs of respiratory distress as the meconium moves from large airways into the lower tracheobronchial tree. Differential diagnosis: perinatal asphyxia, bacterial pneumonia, respiratory distress syndrome, transient tachypnea of newborn, congenital heart disease. Diagnosis: MAS must be considered in any infant born through MSAF who develops symptoms of RD with typical chest X-ray findings. A chest radiograph shows hyperinflation of the lung field and flattened diaphragms. There are coarse, irregular, patchy infiltrates. A pneumothorax and pneumomediastinum may be present. Coarse, irregular, patchy infiltrate with emphysema. Areas of opacification due to atelectasis bilaterally. Left lung demonstration: streaky lucencies of the air in the interstitium. Red arrows complicated by pneumothorax. Arterial blood gas measurements typically show hypoxemia and hypercarbia. Infants with pulmonary hypertension and right to left shunting may have a gradient in oxygenation between preductal and postductal samples. Echocardiogram for evaluation of pph. Management: prenatal management. Key management lies in prevention during prenatal period, identification of high risk pregnancies, and close monitoring. Pregnancy that continue past due date, induction as early as 41 weeks may prevent meconium aspiration. If there is sign of fetal distress, corrective measures should be undertaken or infant should be delivered in timely manner. Management: all infants delivered through MSAF, suction before delivery of shoulders, assess 10 to 15 seconds after delivery, vigorous heart rate about 10 per 100 per minute, spontaneous respirations, reasonable tone, spontaneous movements or some degree of extremity flexion, no intervention. After 15 seconds, if non vigorous, intubate tracheal suction. Management. When the infant is not vigorous, clear airways as quickly as possible. Free flow oxygen. Radiant, warmer but drying stimulation should be delayed. Direct laryngoscopy with suction of the mouth and hypopharynx under direct visualization, followed by intubation and then suction directly to the ET tube. The process is repeated until either a little additional meconium is recovered or until the baby's heart rate indicates that resuscitation must proceed without delay. Postnatal management. Apparently, well, child born through MSAF, most of them do not require any interventions besides the closing monitoring for RD. Most infants who develop symptoms will do so in the first 12 hours of life. Postnatal management. Approach to the ill newborns. Transfer to NICU. Monitor closely. Full range of respiratory support should be given. Sepsis with or without with up and ABX indicated. Treatment in NICU goals: increase oxygenation while minimizing the barotrauma may lead to air leak, prevent pulmonary hypertension, successful transition from intrauterine to extrauterine life with a drop of pulmonary arterial resistance and an increase in pulmonary blood flow. Treatment in NICU. Ventilator support depends upon the amount of respiratory distress. Oxygen hood, CPAP, mechanical ventilation, HFV should reduce air leaks. High frequency ventilators may slow the progression of meconium down the tracheobronchial tree and allow more time for meconium removal. However, high frequency ventilators may slow the progression of meconium down the tracheobronchial tree and allow more time for meconium removal. Treatment in NICU. Surfactant therapy in MAS showed promising result with decrease in the number of infants requiring ECMO and possible reduction of pneumothorax. Treatment in NICU. Inhaled nitric oxide, selective pulmonary vasodilation, activate guanylate cyclase and increases cyclic GMP and acting directly on the vascular smooth muscle. Decreased need for ECMO but no difference in mortality. Pre-treatment with surfactant improves in delivery of INO to the alveoli. ECMO. 40% infants with mass treated with inhaled NO fail to respond and require ECMO. 35% of ECMO patients are with MAS. Survival rate after ECMO is 93 to 100%. Prognosis. Mortality reduced to less than 5% with new modalities of therapy such as administration of surfactant, HFV, INO, ECMO. Chronic lung disease may result from prolonged mechanical ventilation. Those with significant asphyxial insult may demonstrate neurological sequelae. Summary. Optimal care of the infant born through MSAF involves close collaboration between OBs and neonatal team. Effective communication and anticipation of potential problems is a cornerstone of a successful relationship.